My name is Gilliland. I'm here to talk about breast imaging and new techniques. I'm an assistant professor at Emory. I have nothing to disclose. So, what's the most common type of female cancer? My guess is by the name of my talk, you've figured it out. The number one type of female cancer is breast. It's incredibly common. 1 in 8 women will get breast cancer during her lifetime. And the American Cancer Society estimates for this year they estimate that there'll be over 280,000 cases of invasive breast cancer and about 50,000 cases of non-invasive breast cancer. The next most common cancer is lung, with a little over 100,000 cases. So breast cancer is twice as common as the next most common cancer, over twice as common. That's the bad news, but we do have some good news about breast cancer screening. We do a great job of diagnosing it early and treating it. And even though it's going to make up about 30% of the new cancer diagnoses, it's only going to make up about 15% of deaths. And although there's going to be about 280,000 cases of breast cancer, only about 40,000 women will die. This is due to increased screening and better cancer treatments, and breast cancer deaths started to decrease around 1989. So screening mammo is something that women have every year and when they're asymptomatic. And Dr. Kunderman is going to give a talk on screening mammo, so I won't discuss that today. Diagnostic mammo is done to evaluate our patients that are called back. So if you get a call back from your screening mammogram, this is what you'll do when you come back into the breast center. It's also done if you have a physical complaint, if you have a mass, if you have skin thickening, if you have nipple discharge or pain, we'll do a diagnostic mammogram. And this is a little bit about that. So spot compression views are done when pressure is applied to the area that we have in question. So we press on that tissue a little bit to see if it just disperses into normal tissue. And if it does, then we can let you go and you don't have to come back. But if it doesn't, and we can see a mass with some tissue kind of going around it, then we'll have to do an ultrasound and potentially a biopsy of that area. Magnification views are done looking at calcifications or little bright spots on your mammogram. So if you come in for extra views and we tell you to be really still, that's what we're doing. We're getting some really good pictures of those calcifications to determine whether we should send you to have a biopsy or if you can go home. And then ultrasound uses sound waves. We use ultrasound to decide if an area that we see is worrisome or if it's not worrisome. So we can find masses that worry us and we can find cysts that don't worry us. We also use it to look underneath your arm at your lymph nodes. So this is a picture of a mass seen by ultrasound. We can see glandular tissue and fatty breast tissue, and then right here we see this mass that has irregular borders, and it has an angular border right there, and we don't like that. We want to do a biopsy of it. But also, it could tell us that a mass is totally fine. This is a simple cyst. It's just like a little bit of fluid in your breast. And we can tell that this is that because it's oval and what we call anechoic, but to you, that just looks black. And it's well marginated, and we know that's a cyst, and we can let that patient go. Also, it can tell us if a mass is benign. If we think, we probably don't need to do a biopsy of this. Things that are flat and oval, or we could draw a nice line around it that kind of looks like a jelly bean. We know those are benign masses, just like this one. So we can also use ultrasound to do biopsies. We can use ultrasound, we can place a needle using ultrasound and take some samples and send it to pathology, and that means that a patient doesn't have to go under general anesthesia. Also, when a patient does go to surgery, if they have a cancer or something else that needs to come out, they'll go to surgery. And we can place a little marker or a wire in the area that needs to come out to help guide the surgeon so they can get to the area quicker and more effectively. So MRI is a tool that we'll talk about also a little bit later, but it is a powerful magnet. And we use contrast. We inject a patient with contrast, and then we look and see where that contrast goes quickly and where it washes out quickly. So a specific type of blood vessels that are kind of leaky are often seen in cancers. So that MRI is really tracking where that is. It's also used to detect implant ruptures, and we can use it to decide, hey, this patient has cancer. Is there more to the story? Do we need to know anything else about it? So this is a picture of an MRI. This is the heart. These are the muscles in the chest. And right here is the nipple, and here's a mass behind it. You can see it's enhancing. Here's another mass right here. And this patient, you can see that she has a big posterior mass that's enhancing, and you can see that looks different than the rest of the breast tissue. And this is when MRI is incredibly valuable in patients that have been recently diagnosed with breast cancer. We can look right here and we see that there's a mass. But the thing that we can't see by mammo is that mass is invading this muscle right here. And so we'll know that when this patient goes for surgery, she needs to have some of this muscle taken too. And that really helps guide surgery when you have an MRI beforehand. And this is just a picture of an implant rupture. It's a silicone implant rupture, and there's little curlicues right in here. And we know that that implant is ruptured when we see that. And MRI is really the only modality we can see that on. So we're going to talk a little bit about high-risk subgroups, so you can have an idea about what type of screening you may need. So there are patients that are at increased risk for breast cancer, and for these patients, they may need a little bit more than just a mammogram every year. And this is just a general overview of who is at high risk. So patients that have had chest wall radiation, if you've had Hodgkin's lymphoma and had chest wall radiation before the age of 30, that does place you at an increased risk of getting breast cancer. If you've had a personal history of breast cancer, especially when you've had it before age 50, and then if you've had a biopsy that revealed a high-risk lesion, then you could be at risk. So if you had a biopsy and they said, oh, it's not cancer, but you still may need to have it out, or it's kind of high risk, that can cause you to be at increased risk later in your life. And then patients who have dense breast tissue are 4 times higher or more likely to get breast cancer than those with fatty breast tissue. So, and additionally, people with genetic mutations. So if you have a mother and a sister and they had breast cancer early, you actually may have a genetic mutation. The most common types of genetic mutations are what we call the BRCA mutations. You may remember when Angelina Jolie went in and had a bilateral mastectomy with reconstruction. She actually had BRCA1 mutation, and she was up to 85% risk that she would get breast cancer within her lifetime. There are many other genetic mutations, and I'm not going to go into all of those, but they can do a blood test oftentimes and see if you have any of those mutations. Also, people who are of Ashkenazi Jewish descent are much more likely to have their BRCA mutation. There are 1 in 40 people of that descent have the BRCA mutation. African American women are also at higher risk for the BRCA mutation. But in addition to that, they have similar breast cancer occurrence rates of white women, but they're 19% more likely to die. A little bit of this has to do with genetics, and then some of it has to do with the fact that they're more likely to get a really bad type of breast cancer called a triple negative breast cancer. So screening these patients early and with a proper screening tools is very important. Breast density, we talked about that a little bit, but that can make you at increased risk. But more importantly, what breast density does is it makes mammography less helpful. We're not able to see breast cancer as well because dense tissue is white and so is breast cancer. This is just a picture of breast density. This is a fatty breast, and this is a really dense breast. And as you can see, it's very white, and I'll show you what happens with that. So this is a patient with dense breast tissue. She's actually only heterogeneous, but she still has dense tissue. And you can see right here that she has a cancer that she came in feeling, and we can hardly see this cancer. Don't know that we would see it without that palpable marker, and that's because her tissue is so white over that cancer. It makes it hard. And this is another picture just to kind of highlight. This patient's got fatty breast tissue, and you can see this little area right here is a teeny tiny cancer that you can see super easily in this patient with fatty breast tissue, because the cancer is white and the fatty breast tissue is gray. But in this patient with dense breast tissue, you can hardly see this very large cancer right here because it just blends in with that white tissue, and that's the problem with dense breast tissue. And so What can we do differently for patients that are high risk and patients that are dense? So what are the options? So tomosynthesis is one option, which is something that we do on all of our screening patients at Emory, and that's just a 3D mammogram. And then screening ultrasound is when they use ultrasound and a screening as a screening modality. Contrast mammo and molecular breast imaging are looking at enhancement. Contrast mammo with regular iodinated contrast that you'd have with a CT scan, and molecular breast imaging we're going to use sulfur colloid, which is a radioactive substance, and then with MRI, which we talked about earlier. So tomosynthesis increases cancer detection and it decreases callbacks, and that's really a win-win because we don't want to be calling back everyone. We want to call back the patients that really need to come back. So you can see this is a 2D mammogram picture of the same patient, and right here is her cancer, but you really can't see it on the 2D, but once you get that tomosynthesis, you can see it. That 3D mammogram lets you really see inside the breast. And we can see these lines coming out from this, and we're able to find that cancer. And this is just a picture from a tomosynthesis image. This is just a video I want to play really quickly. And I want you to look right here. So right here, we have a cancer that we can see the lines coming out from. And we cannot see it on the 2D view, but when you look back here, you can see this really subtle cancer deep in this tissue with these lines coming out from it. That is a cancer detected by tomosynthesis. So screening ultrasound detects breast cancers in patients using the same modality that I showed you, which was ultrasound. Most of these cancers are small and they're invasive and they're node negative, so that's the good thing about it. You'll detect 3 to 4 per thousand. Which is a little bit less than screening mammo. The problem is it increases recall rates tremendously. So some estimates are by about 285 per 1,000 women screened. And then it depends on who's scanning you. Ultrasound is very operator dependent. If you don't have a great ultrasound tech, it may be very difficult to do accurate screening ultrasound. And the automated ultrasounds oftentimes don't cover the whole breast. This is just a picture of an automated breast ultrasound. These are some complicated cysts picked up by it. So contrast mammo is similar to MRI in that we're using contrast and then we're subtracting, but we're subtracting out after we give the contrast. It's sensitive. The sensitivity is similar to MRI, and we can often see things that we can't see by mammo. Here's a picture of it. So here's a cancer that we can see by mammo. That's very easy. We can see that right here with our contrast mammo. But here's another cancer that we can't see by mammo. So this contrast mammo really allows us to pick up a cancer, a second cancer that we can't see because it's being obscured by all this dense breast tissue. Molecular breast imaging we use technetium sestamibi, and we use a very specific camera. It's very, very sensitive. It's also not impeded by density, and the cancer detection rate is similar to MRI. The only problem with this is that there is a lot of whole body radiation. So when you inject technetium sestamibi, it doesn't just go to the breast, it's going to go over your whole body, and that does increase your radiation dose. But the benefit, is that it definitely sees things that a regular mammogram can't see. So in the future, I think that the goal is to have lower doses and better cameras so that the risk is not so great. But this is just a picture of molecular breast imaging. And then right here, you can see that this patient has dense breast tissue, and here she has a cancer right here that we can't see here. And it's also taking up that contrast or that radiopharmaceutical right there. So this is a picture of MRI. This is the same picture I showed you earlier. And MRI is the gold standard. It's expensive, and there's something called gadolinium deposition that happens. And gadolinium, which is the contrast used by MR, is deposited in people's brains. There have been no bad things that have occurred with that, but it is something that we do want to note. And so screening option for MRI is something called abbreviated MRI. We're actually doing that at Emory, where we do a very quick MRI, and we're really just looking for that first phase of contrast enhancement. So this is just a picture. This is a patient that had bloody nipple discharge. Her mammogram, as you can see, is totally normal. And then in MR, we looked and we found this area of what we call non-mass enhancement. That was on the previous image, and it's right there too. Biopsied it, and that was cancer. And you can see nothing here before on the mammo, and this is the area, completely invisible by mammo. Another patient with a screening MRI, nothing seen by mammo, had 2 areas seen by our screening MRI. Here's the biopsy clips. Both of those areas were cancer. So this is just a summary slide of supplemental screening, but the goal is to find cancers in patients that have breast tissue that's either too dense for mammo to see their cancers and they're at high risk, or they're just at high risk. And every modality has pluses and minuses. Right now, MRI is probably the gold standard, with 14 out of every 1,000 patients detecting cancers that are patients that are high risk, I should say. So these are the higher than average risk patients, and these are the recommendations for these patients. If you really are truly at increased risk genetically, like family members with breast cancer before 40, these types of things, or you have a mutation, then you should really start screening at age 30 and have it every year after that, both with MR and with mammo. If you've had radiation before 30, it's the same story. And if you have had breast cancer before age 50, it's the same story. These people really need to be having MRI in addition to their mammograms, and they need to be screening earlier. And these are recommendations for average risk women. We just recommend screening every year starting at 40 until you have less than a 5 to 7 life year expectancy. The end. Any questions?